morning. I would like to thank the members of the committee for their time today. As you know, the National Scorecard Report of 2011 has shown no statistical improvement in emergency room use for conditions that could have been treated by a regular doctor. Emergency department visits are costly. In a study conducted by Weinrich, Burns, and Malhotra in 2010, they show us how this inappropriate usage, up to 25%, which are preventable, costs us approximately $4.4 billion annually. The Agency for Healthcare Research and Quality, AHRQ, in 2018 measures preventable conditions as those with principal diagnoses related to mental health, alcohol, substance abuse, dental conditions, and asthma. The trends seen in AHRQ's reporting also provide for the strata in socioeconomic disparities, as the lowest quartile of the population has the highest levels of inappropriate ED usage across all measures. Those 18 to 44 have the highest utilization of unnecessary ED visitation related to all the above conditions except for asthma. Asthma itself is segregated into children ages 2 through 17 and adults 19 to 39, with the vast majority of ED visits occurring in the Northeast and again within those with the lowest quartile of median household income. Strategies to help improve this issue have had mixed results. Weinrich, Burns, and Malhotra, again in 2010, tell us that an increased ED copays have decreased short-term usage, but have not had significant effect on overall long-term usage. Patient referrals to post-triage offers the patient an alternative appointment with a primary care physician or a PCP, and the studies indicate about 52% of patients accept these referrals. However, most emergency departments will only make such a referral after the patient has been seen by an MD. This incurs upon the patient an additional visit, which may prove more difficult for the population most likely to misuse the ED in the first place. In Earnhardt and Ganellis' 2013 study, the use of community healthcare workers, CHWs, was shown to be an effective tool for reducing primary care-related ED utilization at the local level and in both the short and long terms. They found that this trend, however, did not abate the habitual overusers of the ED. Lastly, given consideration to the target population's characteristics, a focused effort was shown to illustrate a net cost savings between the program cost and implementation. Decreased recidivism for ailments that can be attended by non-ED visits is the benchmark for quality. The DIMEC model strategy, define, measure, analyze, improve, and control as presented by Porsche in 2019, focuses on quality and process improvement based on empirical data. As most data available is quantitative in nature, this process will complement existing quality improvement controls. Dowd, Carmaker, and Swenson in 2013 have also proposed an algorithm that can be used to assess individual ED practitioners to ensure that their care management is not only appropriate, but also categorize visits into levels of appropriateness. This algorithm also considers ED user choices and inadequacies of their access to healthcare. A national guideline offers flexibility to allow local modalities to mold that program to meet the needs of their specific populations is essential. These population outcomes, as discussed by Porsche in 2019, will allow us to focus on 4 ranging goals: state of social determinant improvements, disparity reduction and ultimately elimination, quality of life improvements related to health, and by utilizing morbidity and mortality statistics, and overall improvement in population health. We would ask the committee to authorize a task force to evaluate the stalled lack of efficiency in conditions that can be treated by a regular doctor but instead result in visits to the ED. Our hope, then, would be for the creation of a national benchmarking policy so that results can be compared, measured, and modified as needed, and thus create a cost-effective, efficient, evidence-based outcomes. Members of the committee, I again thank you for your time and consideration. Please find attached to the briefing all the relevant references as discussed herein. Additionally, the full transcript of this brief will be included. Thank you, and I will now take your questions.